So good morning and welcome back on this occasion of Series 4 webinar on sleep apnea. On behalf of Sun Pharma ENT Classroom, it gives me immense opportunity and tremendous learning on the subject of sleep apnea. Our eminent group of speakers are going to make it furthermore interesting and informative. On behalf of Sun Pharma, I take this opportunity to welcome my all delegates in today's ISSA ET classroom and also our all the eminent speakers. Today, we are fortunate to have Dr. J.C. Suri, Dr. Deepankar Datta, Dr. Jairam from and Dr. Naveen Patel. I'm sure all my speakers are going to make the entire session very, very interesting and informative. With this, I hand over the session to Dr. Naveen.
Good morning, viewers. We are very extremely thankful to you from the Indian Association of Surgeons for Sleep Apnea. You have made us progress. This is the series 4 of ISSA classroom. And we are noticing that we are being viewed outside India also. So I take an opportunity for all those viewers who are watching us outside the borders of India. We welcome you as well. And we will be starting with the ISSA classroom series 4. All those people who have missed these previous 3 series are available into our iassa.in into a subtitle named as ISSA Classroom. You can go and watch it again if you have missed it. Now, I will take pleasure in inviting a very renowned pulmonologist and a sleep specialist from India, Professor Dr. J.C. Suri, who is heading the Department of Pulmonary and Critical Care and Sleep Medicine at Vardhman Medical College and Safdarjung Hospital, New Delhi, India. He is also a founder, president, and chairman of Indian Sleep Disorder Association and the vice president of Asian Society of Sleep Medicine. Anybody who knows the sleep science in India has a big respect for Dr. J.C. Suri. I welcome Dr. J.C. Suri. Sir, please. Hello.
Yeah, shall I start the video?
Yes, sir. Yes, sir. Please. You show your first show your face, sir. Please.
Video.
Yeah.
It's not. Okay.
Yes, sir. Now you are on. Yeah.
Now I'll share the screen. No?
Yeah. Yeah. You shared the screen. While we are waiting for him to share the screen, I take an opportunity to tell all the viewers that we will be issuing a certificate. We are activating a link from the coming series where you will be able to put all your details and a certificate will be issued to all the participants for which a complete detail is required. We have been noticing in last 3 series that there is a lot of incomplete details from the viewers. The essence of getting the correct name on your certificate also would require you to fill in all the details. So we are separately going to put one more link into our login page where you will have to put all your details correctly. Then only we will be able to issue a certificate at the end of the series. Sir, Dr. Suri, please.
Is my screen on?
Yeah.
Okay. Good morning, everybody. At the outset, I would like to thank Dr. Vijaya Krishnan and all the organizers for this very interesting webinar on obstructive sleep apnea. Today, I will be talking to you about the role of CPAP in obstructive sleep apnea and how to improve the compliance. Now, it's very important to understand that why we are talking about this subject. We know obstructive sleep apnea is a highly prevalent disorder, which is characterized by obstructive apneas, hypopneas, due to repetitive collapse of the upper airway during sleep. If this disease remains untreated, it is associated with immediate and long-term complications in the form of symptoms of excessive daytime sleepiness, impaired daytime function, metabolic dysfunction, and increased risk of cardiovascular disease and mortality. These adverse consequences of obstructive sleep apnea can really pose an enormous health and economic burden.
Sir, can I interrupt? You share your screen and put your screen on the thing. We are able to see your face. We are not able to see your presentation. Share your screen as you did last time.
Yeah, just a minute. After making it full, no?
Yeah, after making it full, at a six.
Making it full, there is a green button is there, sir, down.
Yeah.
Share
Green
screen.
button.
Yeah. At the 6 o'clock position, there is a one green button is there. The name is a share screen.
Okay, it's not popping up. That's what I'm trying to see.
No.
Sir, you just did that.
Hmm?
You did just before we checked ourselves. Yes.
Sir, can you see yourself? When you see yourself, then you able to do, sir.
Okay, just a minute. Shall I redo it?
Yes, please. You can do that.
I'll just see.
Sir, basically step by step I will tell you that then first you need to do make it everything in a full screen, sir.
Sir,
Is it okay now? Is it coming?
No, sir, not able to see.
no. You exit from the full screen first and then redo that. I think.
Okay, I've exit from the full screen.
Yeah. Now you will be able to see that.
Which one?
Start sharing the screen.
It's not coming actually.
Sir, you have to go to the Zoom page. You are right now, I believe, on the presentation page. You go on to the Zoom page.
Zoom page.
Yeah. Are you seeing the Zoom screen?
Yeah, share. Shall I press?
Yes.
Yeah, if you see the,
Yes, sir. Yes, sir.
perfect.
We have got it now. Yes.
Yes.
Now you open your presentation. We are seeing your screen. Now you open your presentation.
Yes. Yes.
Correct.
Yes.
Now go to full screen.
Right, sir. Yes, sir.
Perfect.
Is it okay?
Yes, sir.
Okay. Sorry for this glitch. You know, I was there are that screen, there are photographs are coming, you know, these all pictures. Can I remove it? Yes. Yeah, right.
Sir, you can just pull the whole thing down.
Okay, I've done it.
Yeah, okay.
So as I was talking to you that obstructive sleep apnea is a very prevalent disorder and is characterized by obstructive apneas and hypopneas due to repetitive collapse of the upper airway during sleep. And if this condition remains untreated, it is associated with complications and immediate and long-term consequences like symptoms of excessive daytime sleepiness, impaired daytime function, metabolic dysfunction, and increased risk of cardiovascular disease and mortality. The adverse consequences of obstructive sleep apnea can pose an enormous health and economic burden simply because of its high prevalence. Here, you can see the various comorbidities associated with obstructive sleep apneas in the form of cardiovascular disease. We can have endothelial dysfunction, hypertension, coronary artery disease, strokes, and atrial fibrillations. These are due to repeated hypoxemia and hyperoxia cycles, which we see during the apnea, hypopnea cycles. You know, the metabolic complications are in the form of insulin resistance, dyslipidemia, and diabetes. And of course, we have, because of the repeated arousals in sleep, with each termination of each apneas, you have cognitive dysfunction and excessive daytime sleepiness. Now, what are the objectives of treatment? The main objectives of treatment is, first of all, to reduce the symptoms. These are in the form of sleepiness, improving quality of life, and then decreasing the burden of long-term cardiovascular consequences. And ultimately, if we are able to achieve that, we would be able to reduce morbidity and mortality. The effective treatment requires a patient-centered chronic disease management approach that ensures adequate resolution of disease, which goes beyond initial diagnosis and therapy prescription. Because once you start the treatment, it is very important to monitor these patients regarding their compliance and adherence to the treatment. If suppose they are not able to tolerate the treatment, they are not able to adhere with the treatment, or they are facing a lot of side effects or complication, then it becomes imperative for us to provide alternative therapeutic modalities when the primary treatment fails. Managing comorbidities are also very, very important if you want to have long-term benefit with this treatment. And these comorbidities are in the form of diabetes, hypertension, and obesity. So these all requires also to be managed. So what are the indications of treatment? When do you think we should be treating these patients? Because everybody may have some apneas and hypopneas during sleep. Even an apparently healthy person may have 2 to 3 apneas every hour of the sleep. At what particular point of apnea-hypopnea index or respiratory distress index, which is a combination of apneas, hypopneas, and RERAs, that is respiratory effort-related arousals, at what particular level this becomes pathological in terms of long-term consequences? On the basis of various long-term studies like sleep heart health studies, Wisconsin sleep studies, we have come to the conclusion that any patient who has an RDI of more than 15 per hour, or anybody with a respiratory distress index of more than 5 with symptoms or consequences in the form of excessive daytime sleepiness, loud snoring, witness breathing interruptions, and this also includes comorbidities like hypertension, uncontrolled diabetes, and cardiovascular diseases, then these patients should be considered for treatment. Now we have a lot of options for treating these patients, and CPAP, which is continuous positive airway pressure, is definitely the first treatment of choice for all freshly diagnosed cases of moderate to severe obstructive sleep apnea who are symptomatic in the form of having excessive daytime sleepiness. Why we should consider that CPAP is the first line of treatment? Number one, CPAP is the most efficacious treatment. So there is a difference between efficacy and effectivity. Effectivity is on long term in the field condition, whether that treatment is working or not. But at least, when you take a patient of sleep apnea in the sleep lab, and during the sleep lab procedure, the polysomnography, you are able to see a lot of apneas, hypopneas, desaturations. And if you put these patients on CPAP, you will be able to visibly see all apneas, hypopneas, desaturation, and arousal resolving completely, and the sleep continuity returns, the deep sleep returns, the breathing becomes normal. So CPAP is the most efficacious treatment because you are able to demonstrate this in the sleep lab. So that's one. So it is highly efficacious. Second, it is the most extensively studied modality. We have a huge body of scientific evidence in the form of systematic reviews, meta-analyses, which are supporting its efficacy and favorable long-term outcomes. Then there is another situation. CPAP may also help in ruling in or ruling out the diagnosis of obstructive sleep apnea, because the symptoms of sleep apnea like excessive daytime sleepiness, fatigue, tiredness, they are non-specific symptoms and can also be present in other conditions like sleep deprivation. They can be present in endogenous depression. So if we are not very sure that these symptoms are purely because of sleep apnea, and if you do a sleep study and you find mild to moderate disease and put them on CPAP. And if these symptoms resolve completely, then in retrospect, you can say that this patient has purely obstructive sleep apnea. If there is a partial response to CPAP, then there are other comorbidities contributing to those symptoms. And lastly, CPAP can also be used in identifying other phenotypes of obstructive sleep apnea. Now we know very well that obstructive sleep apnea is not purely a small, anatomically small pharynx. It is much more than small, anatomically small pharynx. We have other factors like the arousal threshold, the loop gain things, and the ability of the pharyngeal dilator muscle to respond to these negative pressure reflexes during sleep. So obstructive sleep apnea is basically a heterogeneous disorder where you have anatomical factors, you have muscle factors, you have respiratory control or respiratory control instability factors like loop gain and also the arousal threshold. So by using CPAP, we may be able to actually segregate these kinds of phenotypes in individual patient and then add the necessary treatments, along with CPAP to treat these patients. Regarding the positive airway pressure therapy, CPAP was first developed, or first it was recognized in 1981 by the publication of Colin Sullivan, and first commercial use of this device came in 1986. Initially, these devices were very bulky, very noisy, and they were using the vacuum cleaner pump. Now the modern machines are much smaller, quieter, lighter, and smarter with a wide range of interfaces and functions available. And we also now have many new modes besides CPAP like BPAP, bilevel PAP, auto CPAP, and adaptive servo ventilation. These PAPs are there. How does the CPAP works basically? There are a number of mechanisms by which CPAP is able to stabilize our upper airway and keep it open during sleep. We should know that our pharynx from the soft palate to the vocal cords is a collapsible tube. And during sleep, because of the anatomical factors, because of the muscle tone factor, this segment tends to collapse partially or completely. So what does the CPAP does? It basically acts as a pneumatic splint. So you create a positive pressure in the pharynx and try to keep it open. But this is probably too simplistic way of explaining this whole thing. So basically, when you give positive pressure, this pressure is also transmitted right up to the alveoli and it increases the lung volume. So once it increases the lung volume, it increases the functional residual capacity, and it pulls the pharynx down with the downward traction, and that makes the pharynx wall much more stiffer and make it much more stable and less compliant. With the result, the pharynx is not collapsible during the sleep. So other thing is that when you use CPAP, you keep it open, you actually treat snoring, and snoring is a fluttering feeling where the pharynx flutters and there is a lot of trauma to the mucosal surface of the pharynx. With the result, it becomes edematous. So when you treat these patients with CPAP, the pharyngeal edema decreases. With the result, the pharyngeal caliber also increases. So these are the different mechanisms by which this prevents. Here you can see that on the left side, the pharynx is getting closed because of the backward movement of the soft palate, the uvula, the tongue, and the part of the epiglottis. And once you use a CPAP here, you are creating a positive pressure, which is practically actually pushing the tongue and the soft tissue structure forward. And there is also a downward pull, as I mentioned to you, because of the increased volume. And this can be very, elegantly, you can actually demonstrate it on a CT scan or a MRI. Here on the left side, you can see that a normal person's pharynx in the center, you can see that the pharyngeal opening And on the right side, you can see that once this person is put on CPAP, and there is a significant increase in the size of the pharynx. And this increase in more seen in the lateral direction. So here you can see very clearly by increasing, progressively the CPAP pressure from 0 to 5, 10 to 15, there is a progressive lateral increase in the size of the pharynx. So this is how you can demonstrate that the CPAP works, and it not only keeps the pharynx open and it increases the size of this thing. So how do you actually start the treatment? So once you have a patient with sleep apnea, you take them into the sleep lab and you do what we call as you determine the optimal CPAP pressure, which is required for an individual patient to keep his pharynx open during sleep. And this is and during that process, we what we call as CPAP titration, which can be done in the sleep lab as a full night CPAP titration or as a part of split night study. What basically you do is you gradually increase the pressure and you try to find out a minimum pressure which is required to eliminate apneas, hypopneas, snoring, and arousals which are related to the breathing events. And this should be done in all stages of sleep and in all body position. That means supine position, lateral position, left and right lateral position. And it also should resolve all events in supine and REM sleep to account for the effect of gravity and changes in the muscle tone. It should also maintain oxygen saturation at or above 90%. The mask leak, it's very, very important, should be minimum and appropriate for the given pressure. Because as the CPAP pressure increases, the leak from those holes in the mask also keeps increasing. So there is a leak for a given pressure, and there should not, this is what we call as intentional leak, which is there from the mask. There should not be any non-intentional leak from the side of the mask. So the leak has to be minimum and appropriate for a given pressure. The CPAP titration process can be a full night CPAP titration, where you do a separate diagnostic study and a separate full night titration study, or you can do it as a split night study. In the split night, it is actually in the interest of time and money, both. What you can do that if suppose within the first 2 hours of sleep study, you are able to demonstrate severe form of sleep disorder breathing. Because if it is mild to moderate, maybe during the later part of the sleep, when the REM sleep comes, the disease may be severe. But if you are able to record severe disease in the first 2 hours, then you can convert these patients to a split night study and you can do the titration. The important thing is that you should have at least 3 hours of time period for doing the CPAP titration. Recently, now you can see that a lot of patients are undergoing home sleep testing, and those who are going home sleep testing, and if you find that they have got significant disease, they need to be titrated. So once you have done a home study, you cannot bring them to the lab to do the in-lab titration. And the auto CPAPs have been developed to do the titration of these patients. And there are a number of studies, now we have, where after home sleep studies, auto CPAP titration has been done, and it has been compared with the fixed PAP titration in the laboratory. And you can see here, basically you give this auto CPAP device to the patient to use for a few days to a week or maybe 2 weeks. And from that data, you are able to calculate the pressure to be used on as a fixed CPAP. So there are different ways. You take 90th percentile or 95th percentile pressure and then put it on the fixed CPAP. And it has been seen that both these methods, in-lab and auto CPAP methods, are quite equivalent in terms of adherence and in terms of efficacy of use. So there are a number of studies and meta-analysis which shows that that auto CPAP and fixed pressure CPAP are equivalent in terms of control of OSA, control of symptoms of sleepiness, and quality of life. And in fact, auto CPAP appears to be slightly better than fixed pressure CPAP in terms of adherence. This adherence difference is, I think, something of 12 minutes or 12 to 14 minutes. Although it is statistically significant, but how much clinically relevant it is not very clear. There are others now studies where auto CPAPs have been used for treating these patients rather than only titration and calculating pressure for fixed CPAP. So they have also been used and have been found to be quite non-inferior to the standard fixed CPAP. So the auto CPAPs now can be also used for the treatment of those patients of sleep apnea, those who have position-dependent sleep apnea. So that means if the severity of their sleep disorder breathing is twice more severe in supine position than on one of the sides, or patients with mainly REM predominant sleep disorder breathing. Or there are patients who may have frequent change in their body weight, or they are using certain sedatives, or they get frequent nasal problems in form of allergic rhinitis. That means their pressure requirement may vary over a period of months. These patients may be the candidate for auto CPAP. Otherwise, there is no significant difference between fixed CPAP or auto CPAP as far as the efficacy is concerned, as far as the long-term compliance is, or adherence is concerned in these patients. So the auto CPAP as a auto titrating device and auto CPAP as a treatment device. In the treatment, auto CPAP and fixed CPAP are equivalent in terms of control of OSA, in terms of symptom control, quality of life, and as far as adherence is concerned, again, there is a minor difference of few minutes of better adherence seen with auto CPAP as compared to fixed CPAP, though it is statistically significant, but clinical relevance is not clear. Now, the question is that in the laboratory we have proved that CPAP works and CPAP is very efficacious. In fact, in majority of cases, it completely eliminates the disease. So it is efficacious, but really it is effective. Effective means once the patient uses that device at home, will he comply with the treatment on daily basis? Will he use it for the whole night? That is the important thing. What is the long-term efficacy or effectivity? The term effectiveness of this disorder. There are a number of randomized controlled trials, meta-analysis, systematic reviews, which shows that there is a reduction or reversal of OSA-related signs and symptoms like snoring, daytime sleepiness, unrefreshing and fragmented sleeps, cognitive impairment. There is also has been seen that there is decrease in accidents, increased productivity, and decrease in the long-term complications of OSA like hypertension, heart disease, stroke, and death. Most of these studies have been observational studies. We don't have very well designed randomized control trials to prove this. So these are the various trials, meta-analysis, systematic reviews, which shows that that CPAP works. But what we have seen, from these studies, that it is very good in improving the subjective symptoms of sleepiness. But once you look into the objective parameters of sleepiness, like multiple sleep latency tests, then the improvement is not very significant. If you look into neuropsychological functions, cognitive function, mood, then again there are mixed results. Some studies shows improvement, some studies do not show improvement. There is only very mild improvement in the blood pressure in the form of maybe 2 millimeters to 5 millimeters, depending upon the severity of the disease. So we have observational studies, we have what you called severity-based studies, which shows that CPAP is associated with these consequences. But once we use this CPAP on long-term basis, the reversal of these consequences are not very well, documented. The reasons could be the inadequate compliance, because in most of these studies, we have seen that the CPAP usage has not gone beyond 3 to 4 hours per night. So that's one of the issues, And second thing that many of these neuropsychological symptoms, the sleepiness may also be there due to other problems. And see, the OSA may be just one of the contributing factor in these things. So it's very important that when you are trying to assess the benefit of CPAP, you not only see the number of hours the patient is using the CPAP, but also the outcome parameter. Because sometimes you will see improvement in sleepiness with 3 hours of CPAP use. On the other hand, even if when you use 7 hours of CPAP, there is no improvement in the sleepiness for this thing. So these are just some, this is a meta-analysis which shows that there is a significant reduction in the motor vehicle, what you call the vehicle accidents, motor vehicle crashes. There is a significant improvement. So the major problem with CPAP is its, initially acceptance. So when you tell your patient that you have sleep apnea and you have to use a CPAP device every night, whole night, on long-term basis, there are a lot of problems with the acceptance. So about 30 to 40% of the patient may not accept because they will find it too obtrusive or may interfere with their personal life, their married life, interfere in their intimacy. So those issues are there. And once they accept that the device, they may not actually be compliant or adherent to it on long-term basis. So these are the two major issues, And what we have seen that once a person starts CPAP, the overall adherence is not beyond 50 to 60%. So although there are various reasons, we'll be talking about this thing. So there are different studies which shows that the adherence varies from 29 to 83%, and it all depends on how we define adherence. Ideally speaking, CPAP should be used for whole night because the later part of the night has REM sleep, and during REM sleep, you have much more severe form of disease. So if you use, say, 3 to 4 hours of CPAP in the first part of the sleep and do not do it in the later part, then a significant amount of residual disease is likely to be present and will create long-term consequences. As per the studies which we have seen, the long-term studies like sleep heart health studies, Wisconsin studies, and other longitudinal trials, most of the people have found that you need at least 4 hours of CPAP usage to bring some significant change in your symptoms. Although ideally speaking, the CPAP should be used for the whole night. So from the definition point of view, you will be labeled as CPAP compliant if you are using your CPAP for more than 4 hours. And this definition has been accepted in United States of America for reimbursement purposes. And it has been seen that there is a pattern for adherence, that those who are going to adhere to CPAP will do so within the first week of treatment. So those who are non-adherent will have on an average daily night use of 3.45 hours, and those who are compliant, those who are using on regular basis, have a usage of 6.21 hours. And if you combine these two together, then the average will come something around 5 hours per night. And the important thing is that you can differentiate or segregate compliant from non-compliant people on the very first week of treatment. And that is why it is very important to monitor this patient closely and see that whether they are complying with the treatment, and if they have problems, we should provide them support. And in case they are not going to continue with this treatment, we should be in a position to provide them alternative form of treatment like orodental devices or surgical options for these things. So as I mentioned to you, as far as the CPAP adherence is concerned, the 4 hours is the one which we are taking. But as the goal should be full night of sleep, because we have seen that it all depends. If you ask somebody for subjective improvement of sleepiness, you can achieve it with 4 hours of sleep. But those people who are commercial truck drivers or those who are involved in high safety zone work, if you do their MSLT, Probably 4 hours of sleep will not be enough to make them risk-free in these situations. And if you do their multiple sleep latency tests, we have seen that they need at least 7.5 hours of sleep to achieve the adequate resolution of their sleepiness. So here you can actually see that on the bottom you have the hours of sleep, 2 hours, 4 hours, 6 hours, 8 hours of sleep, and on the other side you have the performance, and you can easily see that as you increase the number of hours of usage, your this thing is improving, this thing. So that is, again, you look into the blood pressure here. As you increase the number of hours per night of the sleep, the improvement in the blood pressure also, that this is the drop in the blood pressure, but you see is significantly improved for this. So what are the predictors of poor adherence? Who are the people who are not going to comply, and who are the people who are going to comply? It is very important that we must look into. The adherence to CPAP is a very complex problem. It may be related to the patient factors, behavioral factors. It may be related to machine factors. It may also be related to doctor factor. How much interest the doctor is taking with the patient. So those patients who are highly symptomatic, who have most severe form of disease, who have a greater perception of benefit after sleep study, are likely to adhere to the treatment. Those people who have a mild to moderate disease, who themselves are not affected by that disease as much as is probably the people around her, maybe the spouse, the sleep of the spouse is affected. And these are the people who are brought by their spouse, and those who are not sleepy, those may have a high nasal resistance. This is a very important thing. If you have high nasal resistance due to hypertrophy, congestion, and this thing, they are not going to use the CPAP because there will be a blockage of the nose. So there will be a poor early adherence. Those who are claustrophobic, it's very, very important. Those patients, these are the people who will not go in the lifts, who will not go into the crowded places. So they have that sense of claustrophobia, are not going to use this thing. So the technology part, the level of pressure, high pressure, low pressure, this probably has the least impact on the compliance of these patients. A number of methods have been, advised to improve the CPAP compliance. We have, developed there has been a lot of technical improvement in the CPAP devices. There have been improvement in the interfaces. All these, different modes have been created, but none of them have been, even auto CPAPs have been created. So if you see unselected patient, none of these have been able to, show a significant improvement in the compliance in this patient. Again, indicating that poor adherence to CPAP is a very, very complex problem. What best you can do is you identify the problem, correct them. So there may be multiple problems. Suppose you find 10 problems in a patient who are interfering with the adherence, you correct them. Still, there will be improvement in adherence, but still it may not be satisfactory because this is a very, very complex problem. What we have seen that what which has worked is the education about OSA and about the PAP therapy by staff using videos, printed information, involvement of the spouse, early intervention for side effects and concerns, and giving them some kind of PAP helplines. These what you call telemedicine, telephone follow-up. This has been given. They have resulted in some improvement. But the most important thing is what we have seen as the behavioral therapies in the form of cognitive behavior therapy, motivational enhancement, education, and frequent provider follow-up. So these are the things, which has improved, I would say, by 10 to 15%. They have been, have been helpful in improving CPAP compliance in this patient. So what I want to say at this stage, that despite our best efforts of patient education, behavioral therapies, cognitive therapies, improving the technology, we have not been able to improve CPAP compliance beyond 55 to 60%. In fact, we have reached a plateau of our CPAP therapy, and there are still about 40% of patients, who are either not accepting or not or not compliant with these kinds of therapies, and these patients requires additional forms of therapies. These are the various side effect and their troubleshootings which are there here. And as I said, the CPAP was not found to be effective in many patients who required high pressure, or those who required who has coexisting disease in the form of obesity or COPD. So in fact, they have an element of hypoventilation and requires a kind of ventilatory support. There are patients who will have central apnea. As I told you, that CPAP, now sleep apnea is a heterogeneous disorder. They may have loop gain issues, and so they may have complex sleep apnea. So they may require additional treatments, besides CPAP. So these are, for that, different modes have been created in the form of CPAP, BPAP-S, flexible expiratory relief valves, auto CPAPs, auto BPAPs, ASVs. All these technological improvements have been done. And with the use of this, as I have mentioned to you, if you take unselected patient, we have not been able to improve the compliance in these patients. But individual patients, these devices, these modes may be very useful. Like, as I said, overlap patients may respond better to sleep apnea, to BPAP. People with central sleep apnea may respond better to BPAP-ST mode, and patients with congestive heart failure may respond better to ASV devices. So like that, patient with overlap syndrome may also respond better to, say, AVAPs kinds of modes. So these have been the important things. Just lastly, in the last 2 minutes, what I want to say that surgery has a very important role to play in the improvement of CPAP compliance. As I mentioned to you, that if your patient, it is very important that once you prescribe CPAP to your patient, it is very important to evaluate the nose of that patient. Because if that patient has nasal obstruction due to maybe deviated nasal septum, hypertrophic turbinate, polyps, or a congested nose due to chronic allergic rhinitis or sinusitis, these patients are not likely to comply with the CPAP. So surgery here is what we call as a adjunctive therapy, and this is basically used to improve the compliance of CPAP in these patients. And we have seen that when you treat the nose, it not only results in reduction in the pressure, CPAP pressure, because if you have a nasal spur or a localized obstruction, it results in significant dissipation of pressure there. So if you remove that obstruction, the overall pressure requirement may become much less. It may also improve the quality of life, and also so basically it improves compliance, quality of life, and also it results in reduction in the CPAP pressure by at least 2 to 3 centimeters. So surgery needs to be considered to improve compliance of this patient. And lastly, some patients, who may require very high pressure of CPAP, those who are very obese, and those patients who have a large tongue, they can also be given some kind of surgical option for the tongue in these cases. Otherwise, you can actually combine orodental device with the CPAP in this, and combining these two, you can pull the tongue forward and result in reduction in the CPAP pressure requirement. So these kinds of hybrid therapies, I think, are also very, very important in improving CPAP compliance in these patients. So to conclude, to summarize my talk, CPAP is the first line therapy for patients with moderate to severe obstructive sleep apnea, especially those with daytime sleepiness. The role of CPAP therapy in patients with obstructive sleep apnea without daytime sleepiness is not very clear. CPAP therapy consistently resolves sleep disorder breathing events and improves daytime sleepiness in symptomatic patients. This all we can see in the sleep lab. There is an inconsistent data concerning the benefit of CPAP therapy with regards to neurocognitive function, mood, quality of life, cardiovascular outcomes across the spectrum of disease severity because of the compliance issue and because of the multifactorial nature of these comorbidities. And despite its potential to improve several clinical outcomes, long-term adherence with CPAP therapy remains suboptimal. Improvement in adherence has been associated with systematic education and with and without behavioral therapies. The roles of other interventions such as heated humidification, hypnotics, telemedicine to improve CPAP adherence remains unclear. The roles of advanced PAP technologies such as EPR, BPAP, AP, auto-PAP and auto-BPAP are not clear as they are not associated with improvement in adherence, daytime sleepiness and quality of life. Auto-PAP used in unattended setting after home sleep testing, either to determine a fixed CPAP pressure or as a primary treatment, is a reasonable therapy for patients with moderate to severe disease without underlying comorbidities. Most of the data on APAP therapy is limited to patients with only excessive daytime sleepiness. Thank you. Thank you very much.
Thank you, Dr. Suri. What a wonderful presentation. We have a lot of questions, and I hope you don't mind taking them.
Sure. My pleasure.
So, sir, the question is.
Shall I go back to? Shall I remove the
stop
screen?
Sharing your screen.
Yeah, I can stop sharing my screen. No.
Yes. Yeah, sir. So the question is that this person who is asking us is what are the complications of CPAP device, which you just briefly mentioned. His name is Dr. Ganesh Bangar from Hingoli in Maharashtra, and there is Mr. Gokul from Trichy, who is how much is the chance of pharyngeal mucosa pressure injury due to CPAP?
No, in fact, on the second question, on the contrary, the CPAP results in the resolution of injury caused by snoring. In fact, that is one of the mechanisms, CPAP works by increasing the pharyngeal caliber, is reducing the edema caused by repeated snoring. So CPAP is in fact a device which prevents injury and cause resolution of edema, number one. And first question was I think the complications you said.
Complications, yes.
The CPAP is a fairly safe device. I would say the complications are not because of the CPAP, but the complications sometimes are more because of the interface. When you are using these masks, nasal masks, oronasal masks, this can cause pressure source on the bridge of the nose, So that probably is the most important thing. Sometimes it may cause some dryness. And if the CPAP pressures are very high, it may actually increase your lung volumes, and sometimes you may have chest pain, and those kinds of issues are there. But by and large, I think it is a quite a safe intervention.
Sir, we have a question coming from our own Dr. Sagar. How do you manage the patients who are CPAP failures? What do? You suggest them DICE? What is your protocol?
See, as I mentioned to you, that we have reached a plateau of our CPAP treatment. Despite our best efforts of technology and compliance improvement, the adherence never goes beyond 60%. So 40% of the patients are going to require some kinds of alternative therapy. So even those patients who are on CPAP, those who are using CPAP, they are not using it whole night. With the result, suppose somebody used only for 4 hours and he sleeps for 7 hours, so 3 hours he is not using CPAP, so he has still significant residual disease. Suppose his AHI score is 60 and he uses for half the night, so practically his AHI score is still 30, which is severe form of disease for this thing. So he still has long-term consequences. So these are the patients, who have to be evaluated for alternative therapy. As I mentioned to you, we have two options: orodental devices. Again, we don't have much support as far as the orodental devices are concerned. The sleep surgery has now significantly developed in India, and we are talking on that forum. Previously, what was the problem was that we had very inadequate means of evaluating this patient as far as the site of obstruction is concerned. We have been using cephalometry, we have been using awake nasal endoscopy, we have been using CTs, and you have been using MRIs, but you were all getting, these static pictures, during the daytime, and we were not able to detect the site or multiple sites of obstruction. And even at that time, I would say till the DICE came, if you see the combined surgery, oropharyngeal surgery and the tongue-based surgery, if you combine both of them, the range of success was something like 30% to 75%. How can you see patients whom you are providing both surgeries, the tongue base and the UPP, still the success varied from 35 to 85%. Clearly it indicated that our means of evaluating these patients were not adequate. And in fact, we were ignoring epiglottis in many of these patients. So ever since the drug-induced sleep endoscopy came, our means of our way of evaluating this patient has significantly improved. Now we are able to better define the site or sites of obstruction. We now see the role of epiglottis, which constitute, I think, about 18 to 20% of the cases who may require epiglottic surgery, or there is also related to tracheomalacia, particularly in children. These issues are there. So I think this is a process in progress. More and more people, as they are using DICE, the important thing is that there are now studies which shows that we are able to now better design and decide about type of surgeries which a patient requires, whether actually it results into better outcomes of these patients. That few retrospective and one or two prospective studies have come which shows, I think DICE has a lot of promise. This is probably at present DICE and dynamic cine MRI. These two, I think, investigations are there at present with us, which have a lot of promise, and we should. In fact, the other thing, which is coming is what is called computerized modeling. In the computerized modeling, you are actually create three-dimensional models, and you do the virtual surgeries. That's another thing which is coming in a big way. And you do virtual surgery and see what is its impact on the critical closing pressures. So those things, I think, have a huge promise. And in fact, I am looking forward to my ENT colleagues in this, and because we have a large pool of patients, I think, who 40% at least would require these alternative therapies. And even those so-called 60% patients, who are on CPAP are partially corrected, and we have to now look for what we call as multimodality treatment, hybrid treatment, where you are going to combine some kind of CPAP surgery, or maybe, combination with orodental device where. So ultimately, we have to evaluate the patient properly, give these options to the patient, let the patient decide, and then, and for like you have a tumor board, in a tumor board of a patient of cancer, you have a radiotherapist, you have an oncologist, you have an oncosurgeon. I think there is a need for multimodality approach for the treatment of obstructive sleep apnea, where we have a sleep specialist, a ENT surgeon, and maybe a dental or maxillofacial surgeon, so that, we can individually evaluate that patient, and then on the basis of that evaluation, what are the best possible options available to us and which can be given to our patient. I think that is what is required. At present, the treatment of sleep apnea is far from satisfactory, as long as we as chest physicians are doing it.
Sir, thank you very much for bringing the topic of multidisciplinary approach to the sleep, and you have been nicely explaining about like a tumor board. We should have a sleep board where everybody stakeholders come under one platform and do the best for the patients. We have a lot of questions coming in. Stay tuned to us, sir. We will take questions when we finish the other two talk.
Sure.
Right?
Sure.
I will be now inviting Dr. Dipankar Datta. He is from Calcutta. He is a good colleague who has been our part of our governing body member also of Indian Association of Surgeons for Sleep Apnea. He is an European board certified sleep apnea surgeon and practicing in Calcutta since 17 years at a Bellevue clinic. And he is a member of World Sleep Society and International Surgical Sleep Society. And he is also founder of Calcutta Sleep Course, which has been conducting courses since 2015. So may I invite Dr. Dipankar Datta from Calcutta to start his presentation on anatomy of surgical upper airway and how it helps in surgical decision making. Dr. Dipankar.
Thank you, sir. Thank you for your introduction and kind words. And good morning to all delegates and participants from India and all across the globe. First of all, on behalf of ISSA, I must thank Sun Pharma for supporting our endeavor to carry on and propagate the sleep science and academics. And thank you, Professor J.C. Shuri, for accepting our invitation. He is a name in his discipline and in the field of sleep. And thank you, Dr. Zimanan, our good old friend from Malaysia, again, for accepting our invitation. So, as Dr. Shuri has told, CPAP, even being the first line therapy treatment for obstructive sleep apnea, there is still 40 to more than 40% chance of long-term non-adherence and lack of effectiveness. So there is role of surgery, and if we need to proceed for surgery, as we all know, understanding the anatomy is utmost important to how to proceed for surgical procedures. So now I would like to share my screen for today's presentation of surgical anatomy of the upper airway.
Today our topic of discussion is surgical anatomy for obstructive sleep apnea surgery. As we all know, the name of the disease obstructive sleep apnea starts from some obstructions in the upper airway during sleep. As sleep is a dynamic event, so it is not only the static anatomy, we have to know the dynamic anatomy, because in sleep apnea, the anatomy is not independent of physiology, and physiology is not independent of anatomy. So there are different levels of obstructions in the upper airway, from the nose, then the nasopharynx, the oral cavity and the oropharynx, and the overall hypopharynx, and overall the skeletal anatomy. Now starting from the nose, as you all know, it is sagittal view of the internal nasal valve, and internal nasal valve is bounded superiorly by the upper lateral cartilage, inferiorly by the pyriform aperture, medially by the nasal septum, and inferior-laterally by the posterior end of the inferior turbinate. Now, the internal nasal valve is the most important area where the significant and the most severe nasal obstruction happens in snoring and sleep apnea patients. And it is important from dynamic point of view also. And this is the nose, the grossly deviated nasal septum. This is the significant nasal turbinate hypertrophy. And this is the significant adenoid. And we can encounter this kind of mass in case of nasal polyp also. And if we encounter this kind of nose, we are for sure, we have to treat this nose for this particular patient, because unless and until I treat the turbinates and the septum for this patient, there is no point of achieving the end result. Now, it is also important, not only the intraluminal nasal cavity, we have to keep it in mind the skeletal aspect, because if there is a significant high arch palate that is contributing to narrow nasal airway, that will be dealt in our next presentation. So the most important zone, the palate, because we know the palate creates the maximum amount of obstruction and the vibration and the snoring arising out of vibration from the soft palate. So the palate is the most important structure, and the fundamental and the basic during our initial career of obstructive sleep apnea surgeon. Now this picture is the posterior margin of the heart palate. This posterior margin of the heart palate is the first landmark where this is the palatine process of the maxilla. This is the horizontal process of the palatine bone, and there is the incisive foramen. It is important because the nasopalatine artery passes through this, and this is the palatine foramen. There are two foramens, greater palatine and lesser palatine. This is important from the vasculature and the blood supply point of view, because palate is supplied by the greater palatine and lesser palatine artery. And the most important landmark here, we call it the first landmark during sleep apnea surgery assessment, is the distance between the posterior end of the heart palate to the posterior pharyngeal wall. This is extremely important. Why? We will come later in our presentation, because unless and until we assess exactly what is the length of the heart palate, it is impossible to assess actually the contribution of the soft palate. So the next is knee point or palatal genu, defined by levator muscle fibers. And levator muscle is a sling-like structure that suspends the soft palate from the cranial base. And levator fibers fuse in the midline in the palatal aponeurosis. Palatal genu, we all know, palatal genu is nothing but a crease, also known as palatal dimple, formed by elevation of the uvula, particularly with speech or gag. During our sleep surgical procedures, before making the patient intubated and under anesthesia, we ask our patient to say ah and mark that, because that is the depression, and the dimple is nothing but the palatal genu. And it is actually, why it is so important? It is important because it is the intersection of the levator palati and tensor veli palatary, and this is actually creating the palatal sphincter, and it is the limit of soft tissue excision in any kind of palatal reconstructive surgery. It is the Lakhan Rekha, because we shouldn't go proximal to palatal genu, because that might result in inadvertent velopharyngeal incompetence, which is grossly undesirable. Now, regarding the next landmark is uvula, composed in the velar segment and formed by muscles and soft tissue inferior to the levator, musculus uvuli, salivary glands, and adipose tissue. We have to know the important thing, that the anatomy of the uvula, but whether we keep uvula or sacrifice uvula, that is beyond the scope of today's anatomical description. Now it is a real live patient dissection, how it looks like. It is a surgical specimen of taken from one of our cleft palate cleft surgeon colleague, just to give you an idea exactly in living patient how our palatal muscles look like. Here, this is the palatoglossus and palatopharyngeus fusing in the midline, and this is the tensor palati muscles, and this region is actually the palatal aponeurosis, and here is the genu. You can clearly appreciate this side palatoglossus and palatopharyngeus, and here palatoglossus and palatopharyngeus, and this is the levator palati. Here is actually the genu, that is nothing but the fusion in the midline in the palatal aponeurosis. And this is the hemulus. This is important during our surgical technique of expansion sphincteropharyngoplasty, where we take a bite around the hemulus. And you can appreciate in comparison to our first picture, remember our first picture today, this is the posterior free margin of the heart palate. Now, pharyngeal isthmus. The retropalatal airway is actually characterized by what has been described as the pharyngeal isthmus. And pharyngeal isthmus is defined by the lower soft palate, lateral pharyngeal wall, superior pole of the tonsils, and posterior pharyngeal wall. And it is the smallest and most compliant segment, and it is the segment most vulnerable to collapse and obstruction with a loss of muscle tone in sleep. Now, it is a mid-sagittal depiction of palatal palate showing transpalatal advancement pharyngoplasty, because this is the picture what I was telling you. Unless and until we can understand exactly what is the length of the heart palate, this is the importance of estimating the length of the heart palate, because in transpalatal advancement pharyngoplasty, we need to reduce the posterior segment of the bony heart palate. Why? Let's see this. There are three kinds of phenotypes. There are three types of phenotypes for palate. One is the commonest variety is the oblique variant. Next is intermediate, and the last is vertical. What is oblique? In the oblique pattern, as you can see, the retropalatal space is more open proximally. The narrow segment is distal at the free margin of the soft palate and the uvula. The cross-sectional shape is deep and conical, and the mid-sagittal shape is oblique, more like a funnel. This is the commonest variety. In the vertical pattern, as you can see, the palate hangs just like a curtain. Here, the retropalatal space is closed proximally. Why? Because the hard palate is too long. So the block is actually not only distally, block is also over here. And the narrowest cross-sectional airway segment is close to the hard palate, and coronal cross-sectional shape is flat, and it is mid-sagittally vertical when we are viewing the patient from face to face. In the intermediate variety, it is open at hard palate but closed at genu. So it is just in between two. And as you can appreciate, as you can understand now, in case of the vertical, this is the most, what I can say, challenging situation, where whatever be the surgical procedure we do at this segment of the soft palate, the surgery is destined to be failure unless and until we do some correction over here, because the block is here. So there is no point doing fancy surgeries over here. We need to advance here. Thank God, the vertical phenotype of soft palate, vertical phenotype of the palate is the least common variety, the least prevalent. So regularly we actually get the commonest is oblique, and the next is intermediate. Now the lateral wall. Retropalatal lateral wall is formed by the salpingopharyngeus muscle with partial contribution to palatopharyngeus. And hypopharyngeal lateral wall formed by the lower extension of salpingopharyngeus, palatopharyngeus, and palatoglossus, and pharyngeal constrictors. This is the hypopharyngeal lateral wall. And this understanding of the anatomy of the lateral wall is very important, because in majority of our cases, we don't see actually the anterior-posterior collapse only. We will discuss later. We see a lateral collapse also. And most of the cases we see actually anterior, posterior, and lateral both kind of collapse. Now, base of the tongue, the next important and our so-called quote-unquote dreadful zone, but it is actually not a dreadful zone, provided we know the anatomy. And what is the most important VIP for tongue-based surgery? It is nothing but bleeding. We scare about the bleeding in the tongue-based surgery. But believe me, for lingual artery, which is the major arterial supply, which is nothing but a branch of the facial artery of the external carotid artery. So lingual artery is quite deep. Actually, we do our job over here during midline glossectomy or tongue-based reduction. We do our job over here, and as we can see here, I will show you later. The lingual artery is quite deep and lateral. I will show you the later coronal section. So if we stick to the midline and maintaining the anatomy just 1 centimeter lateral to midline, there is actually very feeble chance of damaging the lingual artery. What about the bleeders? Actually, what we encounter during tongue-based surgery is the venous bleeding and the lymphoid tissue bleeding, not the muscular, some kind of muscular bleeders, not the lingual artery bleeder. Now, lingual tonsil hypertrophy, majority of our cases we deal with this. This is the grade 0, as per the Friedman classification. This is the grade 0, means there is no lymphoid tissue. And this is LTH grade 1, scattered lymphoid tissue, isolated. This is LTH grade 2, lymphoid tissue covering the entire tongue base, but limited vertical thickness. That means we can still appreciate the epiglottis. Here, LTH grade 3, lymphoid tissue covering the entire tongue base, significant vertical thickness with 5 to 10 millimeter approximately. And this is the LTH grade 4, lymphoid tissue covering the entire tongue base, rising to or above epiglottis, in fact 1 centimeter approximately. And in this kind of tongue base, if we maintaining the anatomy, if we reduce this lymphoid tongue-based lingual tonsil hypertrophy, there is actually no bleeding, and we can significantly improve the patient's obstruction, and we will not encounter the lingual artery bleeding because it is a lymphoid tissue hypertrophy. So you can appreciate the picture. It is actually the lingual tonsil hypertrophy. It is not a muscular tongue-based hypertrophy. So if we correlate, this is we can get a very good result just by reducing this lingual tongue-based lingual tonsil hypertrophy. We can give a very good result. The surgical details will be dealt in separate presentation. And now is a famous picture from our age-old Gray's anatomy picture. So you can see in the coronal section, this is the lingual artery. And what do we actually do our job? In this segment, this is the septum, the midline. So we do our job. So even if we reduce our tongue base from the midline, there is no point damaging the lingual artery. So respect your anatomy, maintain the anatomy and the landmarks. Now the epiglottis. And we know there are two kinds of epiglottic collapse. One is primary epiglottic collapse, where there is no secondary contribution. The epiglottis is itself floppy and holding upon itself. And there is secondary epiglottic collapse, where actually the epiglottis is collapsed by the big, bulky tongue-based tissue, be it lingual tonsil or is muscular tongue base. Now the hyoid. So we know this picture. There are the standard anatomy. It is nothing but the sites of division. What is the division? It is basically the upper part is the omohyoid. That is the digastric. I'm sorry. This is basically the splitting the digastric from the hyoid attachment, and it is the sternohyoid. And sternohyoid and thyrohyoid which split with their attachment from the lower margin of the hyoid will be dealt in hyoid surgery plus. Now before hyoid suspension, hyoid looks like this, and when we split and suspend it, we tighten it with the thyroid cartilage, there is a significant airway improvement. Now facial skeleton, we cannot ignore the role of maxilla and mandible. And the most important thing is knowing the location of the neurovascular bundle, that is the inferior alveolar neurovascular bundle, and what it is distance from the mandibular cortex and the dental tooth root. And as you can see, either by this virtual surgical planning protocol or by doing 3-dimensional CT, routinely we assess before our skeletal surgical protocol exactly what is the distance from the cortex, so that we inadvertently we shouldn't damage the inferior alveolar pedicle. And I am not going to the details of this description. This is important because in advancement genioplasty, we actually advance a chunk of genu, that is the chin tissue, chin bone. And when making the cuts, we have to keep it in mind. We should keep adequate safe distance from the mental nerve and the dental tooth root during doing genioglossus advancement. Now the dynamic anatomy, the last thing, because we all know just by knowing the static anatomy, it is important to correct the static anatomy, but sleep is a dynamic issue, and that is the importance of drug-induced sleep endoscopy, adequately described and detailed in last day's presentation. So particularly for all beginners and the residents, they must understand exactly how we sleep surgeons assess our anatomy through the lumen during doing sleep endoscopy, which will guide us exactly what surgery we need to do and what level. So there are two kinds of collapse, epicollapse and lateral collapse. In the epicollapse, there is a uvular type of collapse and there is a velar type of collapse. Already you know we have described during the palatal phenotype. And this is the epi kind of collapse where it is collapsing from anterior to posterior, and it is lateral collapse, and this is concentric collapse. Most of the cases we actually get concentric collapse, where there is collapse from anterior, posterior and lateral both. Now let me share with you this video. So this is our sleep endoscopic interpretation. This is the sleep endoscopic observation. You can see this is the lower lateral wall. We are within the lumen, and this is how we assess our dynamic anatomy. This is the epiglottis. You can clearly appreciate this is predominantly primary epiglottic collapse, though there is some lingual tonsil hypertrophy, but predominantly the epiglottic collapse pattern in this particular patient is primary epiglottic. And you can see the bulky base of the tongue, mainly lingual tonsil hypertrophy. And during doing tongue-based surgery, if even after lingual tonsil removal, if we need to do, we do some muscular tongue-based portion. And this is the floppy uvula. And if we get this kind of anatomy, suppose from this kind of video, we can clearly appreciate we need to address lateral wall, we need to address lingual tonsil, we need to address uvula, and we need to address nose. Last but not the least, again, back to the initial discussion. Unless and until we treat the nose, because why I am skipping epiglottic? Even if there is epiglottic collapse, this epiglottic collapse may be secondary to gross nasal septal deviation. In many cases, doing a good nasal correction and doing palatal job, maybe along with lingual tonsil hypertrophy reduction, we see there is no more epiglottic collapse. So isolated primary epiglottic collapse is not necessarily always need epiglottic procedure, and particularly when in this patient there was a lingual tonsil hypertrophy. So epiglottic procedure is plus minus. This patient may need or may not need. So thank you all. Unfortunately, because of this COVID pandemic, we couldn't meet during our 27 to 29th March Ahmedabad ISSA meeting, but we keep on sharing this kind of knowledge and looking forward to when this ISSA Ahmedabad we can organize in the long run. Thank you all.
Thank you. Thank you, Dipankar. For all the viewers, that we are going to have a rescheduled 8th annual conference of Indian Association of Surgeons for Sleep Apnea. We will be coming out with the new dates and the new planning for the conference. Temporarily it was postponed because of the prevalent COVID-19 situation. We are evaluating till the end of the May, and then we will come out with the new dates for our 8th annual conference. Dr. Dipankar, I think we keep the questions till the last. Hello?
Sure, sir. Yes, I am here.
Yeah, Dipankar, we keep your questions till the last. I will invite Dr. Jeevanan, who is a consultant ENT surgeon at Pentai Hospital Groups in Kuala Lumpur. Dr. Jeevanan?
Yes, sir. Good afternoon.
Yes. Welcome. Welcome to our ISSS series 4. Yep. He is the past president of Malaysian Society of Otolaryngologists and Head and Neck Surgeons, and he has a very special interest in nasal surgery in sleep-related breathing disorder patients. So nose, as Dr. Suri has rightly mentioned, plays a very major role in compliance of CPAP. So Dr. Jeevanan, over to you.
Thank you. Good afternoon, and it's an honor to be given the privilege to get this invitation from the Indian Association of Surgeons for Sleep Apnea, and also thank you, Sun Pharma. And without further ado, I'll start sharing my screen and getting my presentation going. So I've been asked to talk about managing nasal obstruction in OSAs. Is the screen clear, sir?
Yes, yes, sir.
Okay. I've been talking about this area now for the last 3 years, and I'm basically going to give you an idea of why I'm saying that there should be a paradigm shift in the way we address the nose. So let's run through some basic principles. We know that the nose is the natural pathway for breathing. We are meant to be nasal breathers. And in a recent webinar where I heard Zarus Sagi talk, he mentioned that the need to breathe through the nose, you should be able to breathe through the nose 96% of the time, and the range is between 90 to 100%. But a lot of the time we are not, we don't make ourselves aware that we have to breathe through our nose, and we very routinely become mouth breathers. And what we don't understand is nasal physiology is very dependent on the physical structure of the nasal cavity. And we are beginning to realize that based on new data that's coming out, individual components within the nasal cavity may have an overall effect on nasal function. And physiological function, in addition to breathing, this includes filtration, humidification, and then of course the nitric oxide theory, and with sterilization and pulmonary increase in pulmonary vascularity. And also don't forget that the nose has got a big role in mucociliary function and immune defense, and of course there's the concept of nasal cycle. So when we look at the nasal cavity, it is not just purely anatomy, but we have to incorporate physiology, and we also have to incorporate what is normal and what is abnormal based on the time of breathing, and that's the nasal cycle. So I'm not going to waste time on this slide because most of us are all familiar with this. There's 50% total upper airway resistance is contributed with the nose. And the nasal pathophysiology and the pathogenesis of OSA based on Starling resistor hypothesis about instability of mouth breathing, nasal ventilatory reflex, and also the nitric oxide. So I'm going to go straight into the concept of structure, physiological function, and compensatory mechanisms. So as I mentioned, the primary organ of breathing is the nose. And the structure is not just the nasal cavity, but it is the nose that sits in the entire external skeletal framework in relation to the skull. I'll talk about this more in detail as we go along. And we have to understand that there's a concept of nasal breathing and airflow versus resistance. Now, when we talk about resistance, we never ask, why is there resistance? Why has airflow got to be slowed down? These are all conceptual theories that we are in the process of looking into. Is there a particular way that the air flows? Like if you see on the second diagram, air flows in this particular direction. So is there some filtration going on here, some humidification going on here, and then nitric oxide in the middle meatus? So is there a very particular way that air is supposed to flow? And then does breathing change with age? So we also think that as we get older and older, muscle tone, muscle strength, tissue collapsibility, parasympathetic nasal function, all these things are going to change with age. And as we change with age, are there compensatory mechanisms that are going to be coming into play? So when you're mouth breathing from young, because of unperceived nasal obstruction, you will be compensating this, and as you grow older and older, these things are going to become more and more prevalent and more difficult to correct. So I came up with this concept of airway in relation to age. So what I've basically done is, if you look at the pediatric age group, I now break up the pediatric age group into two, which is 6 months to 6 years and 6 years to 12 years, which is based on the dentition. And you can see, if you look at the structure, changes with growth can alter skeletal framework. And this increased palatal height is associated with deviated nasal septum. And there are studies that are actually coming to show this. And again, when you bring about concept of atopy, non-allergic rhinitis, where there is turbinate and adenotonsillar hypertrophy. So if you look at the structure here, and then if you look at the physiological function and compensation, in children, the altered normal physiology resulting in compensatory or behavioral changes to adapt to structural changes. So our treatment here is aimed at correction of structure and re-establishing normal function. So we should look at less aggressive targeted intervention with better long-term outcomes. Now, if you look at the third group, which are adolescents from 12 to 18 years, then these children have got permanent dentition, and also young adults. The skeletal changes now are much more permanent. And the physiological functions are already getting compromised, but in this young age group, the compensation of these symptoms are very good. And as you look at the treatment, you need more aggressive intervention, and you need more work on re-establishing physiological function, and you may need long-term maintenance of, you need to have some form of carrying on with maintaining these good practices. But the bigger problem comes in older adults. When these skeletal changes are permanent, they're significantly compromised, the physiological functions with much more systemic involvement, and compensatory mechanisms are no longer sufficient. And this may bring about associated comorbids. So even with aggressive treatment, reversibility may be difficult to achieve, and intervention is mainly reducing disease burden from a surgical aspect. But again, when you want to re-establish function, there's long-term maintenance that is needed. So we need to collaborate, or we need to integrate structure and function where the nose is concerned. We need to understand how anatomical structure can relate to physiological function, and treatment must take into consideration the above. So nasal surgery is not just a correction of structural deformity, but to ensure that we re-establish physiological function, and primarily that is to re-establish nasal breathing. I'm going to run this video for a while. So I'm going to show you exactly what I mean here. Now, when I run this video, I want you to look at this area here, okay? And you can see what happens here when the maxilla actually becomes smaller. You can also see that there is an impact on the nasal volume here. And these changes may be very minimal in terms of, the changes may only be millimeters, but they're very significant in terms of airflow and resistance. So if you look at the current treatment paradigm for nasal obstruction, inflammatory disorders, we have this concept of maximal medical therapy, failing which then we talk about surgery. And when we look at surgery for the nose, it is very, very dogmatic in the sense that we limit ourselves to septoplasty, turbinoplasty, endoscopic sinus surgery, valve repair, plus or minus septorhinoplasty. But when we really have to understand the concept that nasal obstruction is an underrated symptom and an undervalued problem to the ENT surgeon. If you look at symptoms of nasal obstruction in children, look at the whole spectrum of diseases that we get: mouth breathing, rhinorrhea, otitis media, eustachian tube dysfunction, orthodontic problem, bruxing, enuresis, forward head posture, restless sleep, small size, poor sports performance, behavioral issues like attention deficit disorder, learning disabilities, frequent awakenings, and snoring. There's a whole spectrum of diseases that whole spectrum of symptoms right across the entire human body that can be attributed to nasal obstruction. And we in ENT are not recognizing this, and we're not looking at the bigger picture. Now, if you look at adults, snoring, mouth breathing, dry mouth or throat on waking up in between sleep, in need to drink water, very, very few patients will actually perceive of nasal obstruction. And in my practice, it's probably only about 10 to 15% of patients who actually walk in complaining of nasal obstruction. And they have frequent awakenings, they have restless sleep, they get up feeling tired, they wake up with sleepiness, and they also have fatigue. And a lot of these patients actually come to you with some form of facial pain and headaches. And a lot of it can be attributed to spasm of the muscle, which is due to clenching or grinding. So it's based on symptoms. Are we asking the right questions? And we also have to realize that in the pediatric age group and the adults, it's not the same anymore. The pediatric age group is a completely different ballgame, and the adults is a completely different ballgame. So now if I see a kid coming in like this, or a young adult coming in like this, I see the tired eyes, the crooked nose, the receding chin, the narrow face, bad posture. All these indicates to me that this is a poor breathing person or a poor breathing individual. So this is a 31-year-old patient of mine who had allergic rhinitis and had never dealt with the problem. And she walked into my clinic when she was 30. And you look at this, she's got a very bad deviated septum. She's got terminate hypertrophy. But just by addressing this, look at a maxilla. That's the typical high arch palate, low set tongue, typical mouth opening. So you have to encompass the entire skeletal framework in this patient if you are going to deal with a breathing problem. Now, this patient doesn't have OSA. Now, this patient has a breathing problem. So, but you know that if you don't treat this, years down the line, this patient is going to have some form of sleep disordered breathing. So now we look at current literature. We know that development of malocclusions can be related to the position of obstruction. So in nasal obstruction, if you have a dentist looking at these patients, they can have class 1, 2, 3 malocclusions equally. Their maxilla is actually positioned posteriorly. Their mandible is positioned posterior inferiorly. And they have a dolichocephalic type of face, which is very typical, elongated face appearance. So everything is squished from side to side and front to back. And I also like to include the adenoids when I describe nasal airway, because I feel that when you're talking about breathing passage, you should separate the adenoids and the tonsils, and the adenoids should be taken together with the nasal passageway. And it's mostly class 2 malocclusions with the adenoids. They have an anterior open bite, and the maxilla and the mandible positioned posterior inferiorly, and they also have a typical adenoid facies. So in assessment, as far as we are concerned in ENT, we are dogmatically taught to consider the valve area and nasal obstruction, the ala, the septum, and the inferior turbinates as nasal, as these are the areas contributing to the nasal obstruction. And then we have to ask ourselves, is visual assessment enough by endoscopy? More so in children. And when we, even now when patient comes with allergic rhinitis, a lot of us get away by just doing anterior rhinoscopy. But if you take it one step further, even if you put an endoscope, should you be looking at an endoscopy before you decongest the nose and after you decongest the nose? Then you have objective assessment like peak nasal inspiratory flow, rhinomanometry, which is more academic and more research-based. But I think a lot of the times we are underusing the importance of imaging. And yes, there is a worry of CT imaging in children. So I'm moving more towards CBCT, which is an area which is very new to me, but this is how we are now trying to use CBCT to see our patients before and after, and I'll talk about this more in detail. And of course, the newer concept of computational fluid dynamics and taking into consideration airway dynamics, which I think is the future. So just to give you an idea with endoscopy, if you were to look at this patient, just without decongesting the nose, just looking at it like this, you will think that this patient has got a inferior turbinate hypertrophy. Same on this side, allergic rhinitis. Septum looks fairly acceptable. And if you decide just by looking at this, you're going to do probably just a turbinate reduction surgery. But let's look at it after you decongest the nose. Now you can see you've got a significant airway, which is much more clearer. You know that there's inferior turbinate hypertrophy. Postnasal space is clear. And if you come up over here, now you start seeing changes over here. As a prominent septal swell body, you can see a paradoxically bent middle turbinate and a narrowed middle meatus. And if you go on to the other side, you can see the septum, the inferior part of the septum now is off the crest. I would correct this. Again, inferior turbinate hypertrophy. Not so much of a septal swell, but again, a paradoxically bent middle turbinate with a very narrowed middle meatus. In fact, we did a ongoing study now with maxillofacial, and we looked at dental facial morphometrics in undiagnosed mouth breathers. And we showed that nasal endoscopy and peak nasal inspiratory flow shows significant unperceived nasal obstruction in almost 80% of the cases. And we also found a significant correlation between increased palatal height and deviated nasal septum. So the role of imaging in surgical planning, you need to have a sort of a software where you can actually look at it in different, different views, either in coronal, sagittal, and you need to plan this surgery. So for instance, if you look at this patient, if you look at this, just one look at it, you think the sinuses are clear, there's not many problems, and you would think that just a septal surgery with inferior turbinate turbinoplasty would be good. But if you look at this whole middle compartment here is very narrowed. So you've got inferior turbinate hypertrophy, you've got paradoxically bent middle turbinate, that's a middle turbinate hypertrophy here, you've got aerated uncinate processes bilaterally. And if you look at this whole patient has got a doxycephalic appearance. So this is what I talk about, the external framework that you have to put in relation. So it's not just this area that we need to look at, it's also the entire skeletal framework that we need to look at. Let's look at this case, for instance. So you go from anterior to posterior, you see septal swell here, and then you start seeing a paradoxically bent middle turbinate, and then you see bilateral conchas. So again, you can see that this is the area that I now focus in. And the reason for this is when we start doing studies like this, if you start looking at airflow, you see the cross-section area, this is the area that I would actually pay interest in. And if you correlate this area on the coronal scan, you can see that it's actually a lot more posterior than what we normally would deal with. And it's actually sitting in this area where the septal swell and the anterior end of the middle turbinate is. This is an enlarged view, and you can see that this is the area that I would be focusing now. And this is the post-op view. Let me show you how it looks like post-op. So you can see now that I've actually cleared up this area, and this area is a lot more clearer now. So if you look at, if we believe that this is the area that we need to follow in terms of breathing, I'll show you some surgical examples later, but we need to rethink in how we address these noses. And these are all patients, you know, that when we do scans, you see very significant changes, but don't forget to include the external maxillary framework, or what I would refer to as the nasomaxillary complex. This is a patient of mine with CBCT. Please remember that we are not talking about inflammatory disease, or we're not doing functional endoscopic sinus surgery. These patients are predominantly normal patients with very minimal inflammatory disease, or sometimes with just simple allergic rhinitis. All you need is a scan to assess the airway. So you can see septal deflection, inferior turbinate hypertrophy, middle turbinate hypertrophy, and this is enough for us to make a decision. And the nice thing about CBCT, and this is something that I'm looking into, is whether we can actually use it for volume demonstration to look at whether we can change volume at the before and after. And we can actually consider doing before and after because of the reduced radiation exposure. So let's talk about surgical concepts. What are the changing paradigms? So I like to introduce this term now called functional nasal airway surgery, or FINESS as a short form. What I'm talking about is a targeted approach. It's structural correction, keeping in mind physiological function. What I think the change is, we as surgeons, when we look into the nose, we want to see big spaces, and we feel that we are happy in creating these big spaces because we feel we have done our job. But I think we know that 50% resistance is ideal, and I think we should be keeping that in mind when we address these surgeries. Because if you create too much of space, you might be reducing that amount of resistance, which might not be good in the long term, because you may not be actually helping in physiological rehabilitation. So the primary step in surgical structural correction before physiological rehabilitation is what we need to keep in mind. So these are the cases that I was telling you about. Now, this is what I want to achieve. I want airflow to move in this direction, going up like this, going down, and going into the posterior coana. So I've done turbinate surgery, and I've opened up the middle meatal area. So this is how a patient would look like before surgery. This is after reducing the septum, corrected the septum. And now you have reduced the middle turbinate, the inferior turbinate, and now look at that middle turbinate. So this is what I would like to see at the end of surgery. So this is the kind of surgery that we need to look at, targeted, very, taking the airway into consideration. And I always address the septal swell much later, not at the primary sitting. So if you get this idea, this is what I'm talking about in terms of functional nasal airway surgery. Now this is about 3 weeks after the surgery. Everything is healing very nicely, and you get a very nice airway that's opened up for breathing, and the patients actually do very, very well. Now, objective assessment in these patients, I think in addition to CBCT, now we need to look at 3D modeling for nasal virtual surgery. The data is already coming out. There's a lot of interesting data, and I think this is the way to go, where we can actually plan our surgeries virtually, and we know exactly how much we need to do and how much we need to address by not doing too much or too little. And you can see here the very nice things that you can virtually do after removing, how you can change the airflow, and how these patients would actually look like virtually before going on. And these are the interesting studies that have actually shown how airflow moves and why I've actually gone into this area of addressing the nose in a very, very targeted manner. So the treatment dilemma, nasal disorders, we always talk about maximal medical therapy. I do not quite agree with this term, because when you have structural obstructions that are skeletal in nature, why do we need to wait for maximal medical therapy? You do maximal medical therapy, but address these surgical issues, and then then you go on. You have to maintain your medical therapy. Now, with regards to OSA, the gold standard has always been CPAP, and I think CPAP still has a very important role. But as far as everybody who manages it, what I want the message to get across is, even if respiratory physicians or dentists or anybody who's managing airway, please look at the nose and clear the nose properly before you address any of these issues. Because a lot of patients with CPAP compliance, if you don't address the nose, they will not look at CPAP again. And it's very hard to convince them, even after any form of surgery, to go back on the CPAP. So I think, like what the first speaker, Dr. Suri, suggested, a tumor board approach, everybody sits together, decide what would be the best targeted approach, would be an ideal way to go forward. And as what Dipankar said, the airway is a dynamic unit with multiple variables. And we have to get into the concept of what is fixed obstruction versus dynamic obstruction. So in conclusion, the paradigm shift, the importance of the nose, both to us in ENT and to other specialties dealing with sleep disordered breathing patients, has been grossly understated and undervalued. The problem is a generic approach in treatment. A surgeon's simplistic view of the nasal cavity may not be doing adequate justice in the treatment of airway disorders. We literally need to look out of the box, and I mean by looking out of the nasal cavity as well. A comprehensive approach to the nasomaxillary complex is warranted. More importantly, long-term follow-up and care in re-establishing function and maintenance is needed. Without doubt, this is truly a multidisciplinary field, and an integrated approach to airway disorders is a must, and it is the future. A shout out to 3 of my best buddies who have actually put me on this track, Yap Yok Yao from Malaysia, Rosalind Simon here, and my great friend Srinivas, who started my adventure in India in 2017 in Hyderabad. With that, thank you very much.
Dr. Jeevanan,
Yes.
you brought a beautiful concept for functional nasal airway surgery.
Yep.
Right?
Yes.
Yeah. And we have a lot of questions, and you brought, I will invite Dr. Surya also to come on. We will start discussion, we'll take questions now. Dr. Dipankar, all of you come online, please.
Yeah, I am there.
Dr. Yes, Dr. Jeevanan, you stop sharing your screen, so we.
Yep.
I have a question to Dr. Suri. That Dr. Suri.
Yeah, I'm there.
Sir.
I'm audible though.
Yeah, we are listening to you, sir.
Okay.
See the pulmonologist colleagues who has been ordering the home-based sleep studies or a level 1 sleep study doing in their own setups, how important it is for them to be seen by, or their noses to be examined. I mean, we want your take, and then I'll take a same question to Dr. Jeevanan.
See, all patients who are being evaluated for sleep apnea, and if on sleep study you have found significant disease, at moderately severe to severe disease, the first line treatment is of course CPAP. But as I mentioned in the talk also, that for CPAP to be effective and on long-term compliance to be good, we should not have any nasal obstruction, because you are going to put the mask on the nose, and if the nose is blocked, this person is going to breathe through the mouth. So your CPAP therapy is not going to work very well. Even if you prescribe, say, orodental device, even then, if the nose is blocked, there will be a problem with the orodental device. So nose, I think, is a very, very important area, and it should be an integral part of examination or sleep apnea patient evaluation. And in fact, every chest physician, everybody who is seeing this patient should learn how to examine the nose.
Right, sir. And a multidisciplinary approach, sir, you brought in is probably the way forward.
Yes, definitely, because because I would say for successful treatment, most of the patient may require a hybrid treatment, multidisciplinary treatment. You know.
So do you see a future of sleep surgery moving into the direction of multi-specialty, where all the specialists are sitting under one roof and then treating, rather than individually treating of their own?
See, as long as we are individually treating, we will not be doing a good service to the patient, because we will be working with our limitations. If I can't fix the nose, and if I don't see that, and if my patient is not using the CPAP, I keep doing, behavioral therapies, cognitive. I told, that the adherence is a very, very complex problem. And it involves, behavioral issues, physical issues, structural issues, issues related to patient, issues related to technology, and issues related to the doctor. So unless, we do all these things comprehensively, we will not be able to improve the compliance. So as I said, that we have reached a plateau with our best efforts so far, which are being done individually. We have not gone beyond 55% as far as CPAP is concerned. So we can move forward, if I think we bring in, we understand more clearly about why this patient is not using CPAP, where is the problems, and I think for that multidisciplinary, not only approach but multidisciplinary evaluation is very important.
Yes, sir. Dr. Jeevanan,
Yes, sir.
as you rightly mentioned about the functional nasal airway surgery, what is the limitation of nose and nasal surgeries in effectiveness of treating a complex sleep-related breathing disorder? So I want you to narrate that, though it is very effective, where it will not be working.
Okay, that's a very good question actually, because I find in adults, especially no matter, like what Dr. Suri said, it is not primarily the nose. You have to look at the entire patient in its totality. If you have a hugely obese patient, no matter what you do in the nose, nothing is going to work. You know that these patients, no matter you do the best nasal surgery, it's not going to work. So in this kind of patients, you may want to consider referring them to a bariatric surgeon, get their weight under control. And so everything has to come in a separate form. You know, it's like exactly like a tumor board. You take a tumor, you want to decide whether this is surgically the best thing to do first, followed by radiochemotherapy, or whether radiochemotherapy first, followed by surgery. So if I take a morbidly obese patient with a deviated nasal septum, turbinate hypertrophy, the first thing I would do is get a pediatric surgeon on board, control his pediatric, get his diet sorted out, a nutritionist, good eating habits, and then see how much of improvement that we get, and then work whether we can put him on a CPAP, whether we need to correct the nose or do other, soft tissue surgery, or, there's so many options available to us. But I think we're all working in our individual silos, as what Dr. Suri very rightfully said. We are not achieving more than 50% in good outcomes. So we really have to have a broader overlook of how we are managing these patients.
Yeah. I have a question for Dipankar.
Yes, sir.
Because this is not related to anatomy, but it is Rahul Shah from Surat asking about disadvantage of EVAC 70 in adenoidectomy.
Disadvantage of EVAC 70?
Yes.
Most of us do adenoidectomy with EVAC 70, I guess.
Yes.
So, yes. So, I probably, what he is actually wanting to ask, whether there is any better wand for doing adenoidectomy or not. And that you had dealt in your first day's talk very nicely, sir. Precise Max being a more aggressive wand, so that is gives a more volumetric reduction with higher energy and power. So EVAC 70 is much less powerful in comparison to that. But having said that, if we know understanding the philosophy of the coblation wand, there is as such no disadvantage of EVAC 70 in doing adenoidectomy.
Yes, dear. Very nice. Nicely answered. And I have a question to Dr. Jeevanan. It's little, how do you differentiate? Is Dr. Rajan Mirai asking from Ahmedabad, how do you differentiate between upper airway resistance syndrome and obstructive sleep apnea?
That you basically have to look at your sleep study. But, I mean, these are basically patients who have got normal sleep studies, but, they have very significant signs and symptoms. See, the problem what we face is OSA is on a different end of a spectrum. We are already looking at the end spectrum of an airway disorder. If you look at how these patients actually develop breathing disorders, skeletal formation, a lot of things are attributed to it. Very narrow maxilla, nasal obstructions. That is why the concept of the slide that I showed, there are changes in relation to age. So you don't develop OSA overnight. You probably develop some form of non-hypoxic breathing disorder. There's a paper by Guilleminot who very nicely describes this. And then you go on to, next step, and then finally you end up with OSA. So having a normal sleep study, and sometimes with patients who almost don't complain of any symptoms, that's the challenge. I would still do a sleep study in these patients because you still see that AHI may be normal, RDI may be normal, but slightly abnormal, but they have a lot of sleep fragmentations, they have a lot of micro awakenings, and you realize that the sleep quality itself is not good. You take this patient who is a non-OSA patient with a breathing disorder, and 20 years down the line, these are OSA patients. So even with snoring, you don't get a patient who is snoring just straight away. They snore when they're tired, or they snore when they have a little bit of alcohol. Then they snore in a particular position, their partner pushes them in a particular way, and then they stop snoring. And then they become heroic snorers, where they snore inside the room, you can hear them outside. And then they progress on to sleep apnea. The whole concept of managing airway disorders is, if we are thinking of managing OSA, we are too late. We are diagnosing the disease and we are managing them when all the problems have already happened. So why I'm going in this direction, the nose and the physiology of nasal breathing may be the first indication of problems which happen very early in life. There was a very nice paper that has come out just 2 days ago. I was brought attention to it. It talks about all the different anatomical structures that are now coming into play when adenotonsillectomy fails to address pediatric OSA. And they found a 40% incidence of tongue tie in these patients. And looking at our data now in the study that we are doing, a lot of these patients who have got unperceived nasal obstruction, who are chronic mouth breathers with very small mandibles, have actually small maxillas and mandible, have got significant tongue ties. And I would advise you all to go and look at Sarush Zagi's, a lot of research work has been done by the Breathe Institute in LA that looks at tongue tie and how its possibilities and how all these things happen. So we have been tied down by a lot of dogmatic practices that says that, you know, this is evidence, this is what we do, this is how it comes. We need to open up the way we are thinking and look at it in a very broader picture, how we're going to address the situation.
Thank you, Dr. Jivnan. I have an announcement coming from Dr. Vijay about our forthcoming programs. Dr. Vijay, you can come on and tell our viewers about forthcoming program. Before I take few questions to Dr. Suri, Dr. Vijay.
Yeah, can you hear?
Yes.
So forthcoming and coming Friday, we are having a session on palatal surgery, and this Sunday and next Sunday we are having some more programs, additional programs other than routine. So this Sunday we'll be having a session on pediatric OSAS, and next Tuesday we'll be having a parallel session again with various surgical modalities will be discussed. And next Friday, we'll be discussing on recent advances in OSAS. And then again, one more Sunday, we'll be having a discussion on tongue-based surgery and how to set up sleep clinic and pre-anesthetic consideration, post-operative management, follow-up, etc. So we have, as Dr. Naveen Patel said, now the forthcoming series of lectures will be very interesting. So keep logging, and at the end of all the sessions, we are going to give a certificate for the attenders who attended all the meeting. So, but after every session, we'll be giving a certificate from the next series. And at the end of all the series, those who have attended all the series will be getting an exclusive certificate, printed certificate from IASSA. So keep logging. I don't want to disturb in between. Sorry for the disturbance. Please continue, Naveen sir.
Yeah. So next Sunday we have an additional program in the evening. Between 6 to 8 p.m. Hello. Yeah.
Yes, sir. Yes, sir. Yeah. 6 to 8 p.m.
6 to 8 p.m. So we are keeping the same series of Tuesday and Friday in the coming week also, but there is an additional program on Sunday, this Sunday, in the evening between 6 to 8 p.m.
Yeah.
Right?
Thank you, sir.
Yeah. I have a few questions to Dr. Suri. That, sir, what are the types of mask and what is the cost of CPAP machine? These are the common questions which I have found, and I've compiled from them a few questions to you.
Okay, means type of masks. Basically, we have the standard masks are the nasal masks from where we started, you know, and then we, as the indications and complications and those things occurred, we went from nasal to oronasal, then oronasal to total face masks, but they are more into actually non-invasive ventilation. Movement, a change from nasal mask to oronasal mask is basically to treat acute respiratory failure. That's more in the ICU. But for sleep apnea point of view, we have basically nasal masks. Then you have very small, what you call mini mask, which only covers part of the nose. And now we have nasal seals and basically nasal plugs. The idea is that to give relief to the bridge of the nose. The bridge of the nose is the most affected area because the skin over the bridge of the nose is very thin. The vascularity is very low. It's like bed sores, So a person lies on the bed for just for a few hours, they can develop bed sores. Similarly, you put a mask and if it is too tight and the vascular supplies compromise this thing and they develop this thing. So I would say the masks are available for different types, different sizes. One should not use one type of mask. They can keep changing the interface to provide pressure, to relief to the pressure points. But at the same time, I want to mention one thing that with change of mask, there can be some change in the pressure. Because if you suppose there are many patients who have problem of mouth leakage. So for sleep apnea, if you use nasal mask, there is going to be mouth leakage because as was mentioned, nose is a area which is very important area. If you are not managing nose properly, these people are bound to open their mouth. And what we do when the mouth is open, the air enters through the nose and come out from the mouth. So you create a nasal-oral flow. So once you create that nasal-oral flow, it causes extreme dryness of throat and these people are not able to use it. So to overcome this problem, you have two options. One option is that you fix the nose, you look into this thing, or you go into the oronasal mask. So once you go to oronasal mask, the dead space increases, the overall things, and then your pressure settings. And if you use from, say, suppose you shift from nasal mask to oronasal mask, now you are bringing mandible also. Because the lower part now is coming to the mandible. And when you tighten it properly, somehow you will push the mandible backward. So if you push the mandible backward, you are going to create narrowing of the space, retrolingual space will become. So now you need more pressure to push the mandible because, even now, even suppose you have tongue, and if you consider tongue as a genioglossus muscle, the muscle has one attachment at the genu, at the mandible, other is at the hyoid and this thing. So if the genioglossus contracts, if the mandible is not fixed, the tongue won't come. It can actually pull the mandible backward also. So when you use oronasal mask, you have a tendency to pull mandible backward. So your sleep apnea may become worse. The same setting which you are using with the nasal mask will change from this thing. So it's a lot of dynamics actually. When we are changing masks, going to different. But I say that one type of mask sometimes can be a problem because it has continuously, it will put pressure on same areas. So if you keep changing, nasal seals, nasal mask, mini mask, in between you are changing to maybe oronasal sometimes. So, but we have to be aware of the impact on, on the nasal passage and the pressure requirements. These things should be clearly understood and discussed with the doctor. So whosoever is prescribing this thing, you need to make necessary changes in the machine and the settings.
Thank you, sir. And I have a question for Dr. Jeevanan. What is his method of reducing the inferior turbinate?
Now what I do is I only reduce the inferior turbinate up to the anterior face of the middle turbinate. I don't go all the way posterior. Now, and my favorite is I use coblation, either using a PTR1 or a turbinator 1, depending on how much I want to read, depending on how big the turbinates are. Yeah. And that's all I do. I'm not very aggressive with the inferior turbinates nowadays.
Yes. We are almost at the end of a closing of our session. My sincere thanks to Professor Dr. J.C. Suri for accepting our invitation, and such a senior person blessing us in our ISSS series is a big thank you from all of us. Dr. Jeevanan, a very big thank you to you from coming all the way, addressing to us from Malaysia, and bringing out the concept of a functional nasal airway surgery to our viewers. Thank you very much. Dipankar, I have a lot of questions, but probably we are running short of time. Dipankar, you made the day by elucidating the importance of an anatomy in our management of sleep disorder breathing. So my sincere thank you to all my panelists. Thank you, viewers. I'll hand over to Mr. Amrish Sahai for closing remarks.
Indeed, thankful to you, sir. While we conclude today's series 4 of our webinar, let me convey my heartiest thanks to all my eminent speakers for making the session so simple, so interesting, and so informative. Thanks a lot, Professor Suri. Thanks a lot, Dr. Dipankar Datta. Thanks a lot, Dr. Jeevaram. Thanks a lot, Dr. Nabil Patel, for moderating these sessions so beautifully. Thanks a lot to the immense contribution for beautifully organizing the topic and the scientific content, Dr. Vidya Sagar, Dr. Srinivas Kishore, Dr. Vijaya Krishnan, Dr. Vikas Agarwal. And I'm indeed thankful to all my delegates for sparing their valuable time this morning. And indeed thankful to the digital team for providing the flawless audio and video. With this, we conclude today's series 4 of our webinar on sleep apnea. Thanks a lot to everybody.
Thank you. Thank you, everyone.
Thank you. Thank you.
Thank you.